Okay, so I am reviewing renal problems, chapter 45, if you're following along with um, AD1. We are going to specifically hit on subjective and objective data to include UA, but not the actual diagnostic, the IVPs and some of the other ones. So we'll look at lab values, but not any of the actual scopes until another video. So let's start off with subjective data. Subjective data, again, remember that subjective data is going to come from your patient or your family, all depending on who you're relying on information from. So subjective data, you're going to start with questioning your patient. All right. You're going to need to know about any type of history that the patient might have with UTIs, surgical history, hypertension. I'm going to break that down in a second. Hypertension, diabetes, gout, metabolic issues, TB, hepatitis. Okay, I'm going to stop right there and let's go through why we're asking these things. Okay, first of all, one, if you had a UTI before, you probably already have the risk factors for a UTI. So it's one of those things that is reoccurring. Right, hypertension. Basically, if you remember back to your, I'm going to write this out one more time. Your glomerular filtration rate, GFR. All right, so if you go back to your actual nephron and you're thinking about the functional unit of it, if you have hypertension, you're going to get a blast of fluid pushing through, all right? It's constantly under pressure, all right, and it's pretty much assaulting this your nephron or your filtration. And when that happens, what ends up happening is you'll get damaged areas, and soon you end up with things that are not supposed to be in your urine. Um, Maybe it's albumin, or it could be a certain type of drug. But either way, when you are under a lot of pressure in your nephron, you will end up making holes in it that it's not supposed to be there, big holes. And when these big holes are there, you might end up with blood in your urine or something of that nature. Basically, like think about the nephron as like piece of tissue paper. And if I keep throwing rocks at it, eventually I'm going to make a hole. And when I can make that hole, I can let bigger things pass through. So that's kind of what the hypertension is doing. Now, diabetes is specifically, it's horrible for your blood vessels. And there's a lot of different reasons why they think that is, but it's not completely understood. Either way, when you have diabetes, you have a lot of glucose running through your system. And when you have that, it ends up destroying those vessels. So if I destroy the blood vessels in my body, not only am I going to, one, create more fluid passing through, but two, I'm going to actually ruin the atrials in here and all of your filtering processes, your tubules. So that's why diabetes is important. Gout. Actually, I spelled that. Anyways, gout. So gout is bad because you're going to have buildups of uric acid. And when you have that, that can also cause factors. So if you have gout, then a lot of times that comes out in your urine. Metabolic issues. All right, so anything hyper or hypothyroidism, which affects all types of different things. If you have hyperthyroidism, your body could be processing things a lot quicker, changing your urine output. Or hypo, maybe you have a very slow metabolism and things not being processed quite as quickly. Hepatitis obviously affects the liver, and of course TB. And when you affect the liver, you're going to affect the kidneys because everything has to be processed out. The liver is your place where everything's going to get detoxified. And your renal system is where they're going to take those toxins and flush them out of your body. So if the liver's not working properly and filtering all your waste, then your kidneys are left to take care of all of that. And that's why it relates back to the kidneys. Okay, so that's why, and again, I'm all about the why. Let's stop memorizing and start understanding, or at least that's what helps me. Anyways, all right. So Neurological issues. So, and these are vast, but neurological issues. Maybe you have incontinence, or maybe it's a matter of dementia. There could be a lot of different things for the neurological, but if you're think about it in a long-term care setting, and that kind of helps you understand. You're going to have incontinence. You might have somebody not wanting to drink fluid. You might have people that have problems swallowing. You might have somebody with a stroke that can no longer feed themselves, and that's going to affect your renal system. All right, medications. So we've got history, neurologics, medications. Now there's all types of different medications to be aware of, and I'm just going to hit on the main ones that we have in here. First of all, the first thing is that some medications are going to change your urine output. It could change the smell or color. All right, and of course, when we think color, we're thinking orange, and we're thinking orange because of azo or pyridium. All right, and that's used for pain, but azo is the brand name. And that changes the color, and that's important to know if a patient's on that rather than thinking that they're bleeding. Smell. Some of them are going to change the smell, and of course you are going to have diuretics that affect your output, or you might be on some other type of medication that decreases your output. The other thing to think about is toxicity. All right, so if our renal system is not working properly, all right, then toxins are going to build up in the body instead of being wasted and excreted out. Some of the most important ones, or the ones that I'm going to hit on at least, that are that create nephrotoxicities are the cephalosporins. Cephalosporins. I'm not sure if I spelled that correctly. Gentamicin. Vancomycin. So these are your strong myosin. And then of course you have other things like cocaine, heroin. Surprise, surprise, that's fat food. Lithium, and of course your NSAIDs, which are all over the place as far as that goes. Quinine. Any of these drugs are going to affect the permeability of those tubules, or are going to create a toxicity in your body that can't pass through. Now, remember back to that nephron. If the hole is not big enough for one of these medications to fit through, the molecule of medication to fit through, then it cannot be excreted, which means that it's going to build up in the body. If you normally are able to excrete it and you have some type of blockage, then some of this stuff might not get out. And that's true of several medications, not just these ones, but of tons of different medications. All right, anything that affects the musculoskeletal or nervous, like let's say I take a drug that's going to be a muscle relaxer. Okay, well, remember that your bladder is a smooth muscle, and your sphincters, you have your sphincters. Well, while one is external and you can control it, the other one is not. Either way, if I take something that's going to create muscle relaxation, then a lot of times I'm going to have incontinence because of those sphincter muscles. And again, they're made of either smooth or skeletal muscle, depending on if you're talking about interior or exterior sphincters. Okay, what else do we want to ask our patients about? So far we're talking to our patients about history, and I know that we just hit on medications and prior UTIs, but this should include surgeries and issues with UTIs, any neurological things, stress, and I'm talking about the 6 facets. So think about everything about your patient when you relate back to the history. Diabetes, hypertension, anything that's going to affect the rate at which things are pushed through the body, your blood pressures, and your gout, anything of build up in the body. All right. What else do we want to ask them? We of course want to ask them how they feel. It's important. All right. So It could just be that they just don't feel well. A malice, I'm not sure if I'm spelling that right. Malice, just generally not feeling well. Can't really describe what's wrong. Blurred vision, disorientation, and this is especially true in older adults, disoriented, confused. Now, there's a couple of things we need to know. First of all, um, we have the lower urinary tract symptoms, and then you have your upper urinary tract symptoms. So remember that lower is going to be your bladder and urethra, and that upper is above, pretty much above your belly button. That's your ureter and your kidneys. When you have an upper urinary tract infection, it's systemic. All right, systemic means that I'm going to have fever, I'm going to have chills, I might have nausea, vomiting. Systemic means my entire body. When it's a lower tract infection, I'm talking about it urinates, it burns when I have to pee, things of that nature. It's not going to cause a fever necessarily because it's controlled in that lower region. It's not systemic, not throughout my body. So that's important to note as far as your lower and upper um, urinary tract infection. What else? Okay, so disorientation, especially important in older adults, blurred vision, malice, and of course you have those ones that are systemic. So if it's the respiratory, upper urinary tract, it's going to be your fever, your chills, your nausea, your vomiting, and then of course your kidneys. All right, if you have, I'm not a big fan of this abbreviation because of course there's a million different types of abbreviation with CBD, but basically, if you have kidney pain in your lower back, lumbar area, or the costovertebral angle, then you are going to have the kidney pain. And we remember we call it a kidney punch, but it's just that palpitation on the back, on the lower lumbar area where the kidneys would be. And that is an indication, of course, of a kidney infection and therefore an upper urinary tract infection. Okay. Jobs. Certain jobs, of course, anything that exposes you to chemicals or doesn't allow you to drink or urinate when you need to, it's going to create a problem. All right, if you hold urine in, you're going to eventually end up with deteriorated sphincter muscles and a buildup of all the minerals and toxins that it is trying to get excrete. So that's never good. Or if you're very, very sedentary, and this actually is not just jobs, but more activity. If you're sedentary, you're going to lose bone mass. Your body's going to say, I no longer need to have this much calcium in my bones. So what is it going to do? It's going to start breaking down those bones, and it's going to put calcium phosphate specifically into your bloodstream. When you have high calcium phosphate, well, you have renal caniculi unless you're able to excrete it. So sedentary people will be more prone to issues with the renal system. Oh, yes. Location. This is kind of interesting. So if you're by the Salt Lakes, and if you've ever, I don't know if anybody's ever been over there, but the Salt Lakes, the osmolality of that is you cannot think. It's crazy. But basically, there's so many minerals around there that when people are drinking water that's been filtered through the soils near this area, they're taking in a lot more minerals than they normally would, and that creates issues. Of course, you want to know about vitamins, now that I'm talking about minerals. Vitamins that they're taking, right? If they take, half a can of Flintstone vitamins a day, that's going to probably create an issue besides your deep fat soluble vitamins. Okay, high levels of protein. This is going into nutrition now. High levels of protein are going to affect some of your creatine, your bone levels, which are really important for identifying issues, and we'll hit on why that is in a second. Patterns of urination, and this is going to be the most significant factor here. Patterns of urination. This is very important information to get. So if they're waking up twice a night, and they're 65 and older, somehow that's okay according to the book. Once a night is okay too if you're younger, but if you're getting up 5-6 times in the middle of the night, then that is a pattern that you need to be aware of. A lot of times people will stop drinking fluids if they have to keep getting up at night, and So that will create issues as well. All right, you want to know how much urine are they excreting. You want to know the color. You want to know the smell. You want to know when it's happening. You want to know how much fluid they're intaking, obviously. All right, if you're dehydrated, well, you have, not enough water and tons of solutes or particles or minerals, whatever you want to call them, that you need to excrete, then you're going to end up with a very high osmolality, and we'll talk about that in a second as well. And of course, you have your mobility issues. So if I can't get up and use the bathroom, then I might have an incontinence issue. I might not be able to make it to the bathroom on time. I might drink less water. Those are certain issues as well. Genetic issues. The polycystic kidney disease, that is genetic. So there is some genetic linkage here, and if they have a family history of UTI, that also puts them at risk. Okay, so family history. So far, let's sum that up. Subjective information that we are looking at from our patients, of course, we want to know about your elimination patterns, that's your frequency, the amount, when are you going, patterns. You want to know about nutrition, that includes your water intake. You want to know about medications, and don't forget herbal medications in here as well, green teas, diuretic, any medications that they take. History, you want to know history of any renal issues, anything that increases the amount of blood pressure, so hypertension, or if they're on medications that are going to raise that blood pressure. Antidepressants are also going to be, and that actually doesn't know, antidepressants have the sedative effect, and a lot of times going to disrupt the sphincter muscles. And again, anything that causes muscle relaxation may create an issue here, and that includes some of your calcium channel blockers. So your calcium blockers can also affect the renal system. So anything that affects the sphincter muscles, the nephron's ability to filter, excrete, or the pressure going to those nephrons is going to affect your renal system. All right, so we need the history and antidepressants, renal issues, hypertension. Of course, pregnancy. If you've ever been pregnant, then you know that you lose a lot of your sphincter muscles there as far as the bladder goes. Another one that I forgot to mention, constipation or prostate issues. If you look at your prostate and where your bowels are, if you look at those two, then you'll realize that any pressure in there is going to create pressure on the urethra, and that's going to affect your ability to urinate, аюрия, or without urine. Alright, so those are subjective factors. Again, there's a lot more of them, but these are the prime ones that we want to hit on. Alright, let's look at an objective, and here we get into lots of values that we need to remember. So let's see if we can't get all the values in one little area. Alright, so objective information, of course, is information that we are going to gather. Again, think about CSI, you're a CSI detective, and figure out who did what when. So objective. Alright, so we should be looking at skin. What does skin tell us? Well, it's going to tell us if it's dry, then especially your mucosal membranes, mucosal membranes, if those are dry, then a lot of times that indicates dehydration. Your mouth, alright, ammonia. I'll talk about that when we talk about our vitamin creatine levels. Alright, ammonia, edema of any sort. So if I can't excrete things, what is my body going to do with the extra fluid? Well, the answer is it goes into second or third spaces, areas it shouldn't be in, which is creates edema. So it's going to push that fluid out. It goes, I don't know what to do with this. So it pushes it out from your intravascular spaces into your interstitial spaces in between the cells. What else? Kidney enlargement. So kidney pain enlargement. So remember you're going to do your inspection, palpitation, all that other stuff. And remember there's a different order for abdominals if you want to check that as well. So there's a different order for the abdominals. You have to auscultate before you palpate and percuss and palpate. All right, kidney enlargement. Remember that your one kidney is going to be a little bit lower just due to that liver being so large, of course. See posturovertebral angle pain, and that's exactly where your kidneys are in your lower lumbar. If you have a bruit, you're checking your four quadrants. But this indicates if you hear that, it indicates decrease in blood flow. You shouldn't be hearing brewing in that area. Pain on urination, of course, is an indication. The amount, if you're only excreting a little urine, that's going to be another indication. The frequency that the patient goes. And if you're giving them tons of fluid and they're not going, then there's an obvious issue. Like I said before, urea is A means without, and then of course urine. And of course polyuria is lots of urine. Nocturia, not nighttime. And then urea, urination. So we are looking at all of these things. We're going to be looking at the color. And also, remember, color can be changed by foods that they eat. Beets is going to change it red. Asparagus is going to make it smell. I heard that shamrock McDonald's shake changes it green. Azo or pyrimidinium changes your urine orange. Asparagus, beets. Alright, so these are things that are going to affect the color, smell of the urine. So ask what they ate as well. Alright, and those are your major ones. Now let's look at, so we sent them, they've come in, they have issues, we know that. So what are we going to do after that? We're going to send them for labs, right? Because we need to actually have something to work with. So here's the way this works, and I'm going to draw this up one more time. But basically, you have that nephron, and hopefully you've seen the first video, or this drawing's not going to make any sense to you. You have your nephron, and he's got all this, the afferent and efferent atrials. Basically, you've got fluid coming in, all right, and in here you're going to have it filtered. And out comes pretty much plasma, but and this filter is supposed to hold back red blood cells, all right, and then you have your efferent, then it goes back out to the body over here. All right, so now here's how this works. Now a lot of your lab values are based off of creatine or proteins or a breakdown of amino acids, and the reason why that is because in the liver, first of all, of course, you eat proteins, and it could be other sources as well, but let's say you eat the proteins. Your stomach's going to break that down. It's going to be sent to the liver because everything is sent to the liver to either be broken down, detoxified, whatever the case may be. So it's sent to the liver. That's my liver. So it's sent to the liver, and in the liver we break down several things. One, we break down creatine. Creatine, as you're used to seeing anyways. We break down many of our amino acids to urea. So amino acids are, of course, the building blocks of proteins. Amino acids are broken down to urea. And then you have ammonia byproduct over here as well, which is why you can smell ammonia on somebody's breath if it's an indication that something's not working well. All right, so some of the proteins are going to give you an ammonia byproduct. All right, what else? Creatines. Oh, creatines and nope, that's it. All right, so your liver again. So your proteins are broken down in the stomach, given to the liver. The liver is going to take that protein and break it down even farther. So you end up with some of the byproducts of proteins are creatines, urea, and ammonia. Okay, so those are what you end up with. Now, from there, these things are sent to your kidneys. All right, so they're sent to the kidneys from there. And in the kidneys, your body is going to excrete it or keep it, okay? The reason why we use so many of our lab values are coming from proteins is because it gives us a good indication of whether or not the body's still filtering it. Now, proteins are a rather large molecule and generally will not filter through this thing right here. So it'll get stuck back here. Proteins will get stuck back here with your red blood cells. Now, creatine is a broken down version of it, and creatine should just about always get through. What shouldn't ever get through is albumin, obviously red blood cells, red blood cells, albumin should never get through. Ammonia should get through. Creatine is small enough to get through, so creatine is going to make it through this thing. Creatine should be excreted. Blood urea nitrate. So your bun levels come from this urea factor right here. Again, a breakdown of protein. So bun levels are coming from your blood urea nitrate, and again, that's your urea. You should have bun coming through here, but in a certain amount. But basically, it comes down to this. If I can figure out what proteins can fit through my nephron on a regular basis and then look at my values, either in my blood or in my urine, then I can determine if everything's being pushed out or kept the way it should be. All right, and that's where we're going to get a lot of these lab values from. All right, so now that we understand that a little bit more, let's look at some of our lab values. All right, so first things first, your analysis is only good for 1 hour. Unless, of course, you do something else with it, but pretty much you want to use it in 1 hour. You're going to have your 24-hour urinalysis that you're going to have to collect, but that's the only exception, really. All right, so let's start with creatine clearance. Okay, now I told you that creatine should be filtered out. It's small enough to get through that filter. So if it's small enough to get through that filter, then that means I should have some creatine in my urine. All right, now let's say that I measure my urine creatine. So this is in my urine. And maybe it's, whatever amount it is. We have to, of course, we have to take amount into factor. So if they give me a 50 milliliter specimen, then I'm taking that into consideration. I'll figure this out. All right, so we have the creatine in my urine, and then I have my serum creatine. All right, so basically what this is this is how much my body is pushing out. This is how much is left in my blood. All right, so if I look at this and I say, hey, I don't have any creatine here, and I have tons building up in the blood, then we have an issue because creatine should be making it through the filtering process. All right, and this is the most accurate way of figuring out your GFR. Now, just as a side note, the GFR in the book is referenced as 125 milliliters per minute, but I have also heard today 100 as a GFR rate. So just know it does vary. There is, of course, going to be things that affect this ratio right here. For instance, if they take a bunch of creatine, or they have catabolism, breakdown of muscles, strenuous exercise is going to affect it. But basically, this is your most accurate way of figuring out your glomerular filtration rate. How fast is my protein going from my blood into my urine. All right, and again, creatine should get through, so I should have some creatine. The levels for your creatine clearance are going to be 70 to 135 milliliters per minute per meters. That's reducing. But anyways, body surface area. So just think 70 to 135 for your serum clearance. Okay, now there is another creatine value, and that relates just to blood or just to urine. This is, I'm comparing and contrasting things, okay, to figure out what's going on with my GFR rate. Composite urinalysis, those are all your values. You're looking at electrolytes, you're looking at all types of stuff. Or you might see your CMP, complete metabolic panel, as a different way of assessing values. Clean catch. Clean catch is a technique. Basically, the bladder itself should be sterile. All right, bladder is supposed to be sterile. Your urethra, of course, has a bunch of germs and nastiness, bacteria in the urethra. All right, so here's your bladder. This should be sterile, and then here you have your urethra, and then outside of the body. I'll give it some kidneys because right now it doesn't look the way I want it to. All right, so it looks like a puppy dog. Anyways, this should be sterile. All right, and this is going to have a bunch of bacteria. And if you have bacteria, we're probably going to have white blood cells. So what we're doing here in your clean catch process is basically trying to catch urine midstream. So what I'm going to do is I'm going to allow urine to fall. One, you have to clean the area, right? Then you let them urinate, and hopefully that gets rid of a good amount of the bacteria and white blood cells in your urea, so that you can get an idea of what's exactly up here in this bladder. All right, so the clean catch process is, of course, cleaning, starting to urinate, catch midstream, and then trying not to contaminate that specimen, and that's going to be important too. For a female, once they are able to do this, you want to make sure that the area that's clean doesn't touch a dirty part, so they need to continue to make sure that's open. Alright, and your white blood cells, 10 to 3 milliliters of white blood cells. Anything greater than 10.5 is of concern, and of course that might indicate that we have an infection that is calling on white blood cells into the bladder. Okay, so 10.5 or greater for your white blood cell count is going to be an issue. All right, we also have concentration tests. I know this is confusing the heck out of people. All right, concentration test. What is that? So basically, all right. Here we go. We have got one container right here, and I'm going to add the same amount of water to these containers. All right, here's water, right? I'm going to make sweet tea, so I'm going to put in a tea bag, all right, in here. All right, and this one I want to make extra strong, so I'm going to put 3 tea bags in here. All right, so what happens? All right. The water, whatever the most amount of fluid is in here, is called the solvent. All right. So in this case, the water is a solvent, and the solute, all right, is your tea bag. That's a smaller amount. Now, when we talk about concentration ratio, all right, is one that has more tea bags in it or solute going to be less or more concentrated than one that only has 1 tea bag? Well, and of course you know the answer is this is going to be stronger, alright? And by stronger we mean that we have more particles of tea floating around in here, okay? So this will be stronger in comparison to this, alright? So when we talk about your osmolarity, I cannot say that word right now, osmolarity, we're talking about how much of this stuff is floating around in comparison to water or your solvent. Alright, so when we're talking about urine, we want to know how much urine to tea or minerals and vitamins, creatine, whatever the case may be, is there. Alright, and so our concentration test or osmolarity test is 1.003 to 1.030. And again, here is my amount of, let's measure it in another container here. Here's my amount of urine. All right, how much of this stuff do I have floating around? And by this stuff, I mean maybe it's white blood cells, maybe it's creatine, maybe it's minerals, whatever it is. All right, whatever it is floating around in here is going to increase my concentration. So the more stuff I have floating around in my urine, the higher my concentration. What does that mean? That probably means that either I have not enough water in my body or I have too much concentration. Either way, we have an issue, okay? And so that's why you need to know your creatine, your concentration test. All right, so that's your concentration test. As a side note, on all of these ones, it's important to learn your role as a nurse. In concentration tests, you have to get, first of all, there's a fasting it's a fasting test. So they have to not eat before. And then you're going to get 3 times. Remember, your morning one is going to be the most, concentrated because you've been sitting there all night. So it's the most concentrated one. But it is important to look at the nursing roles in each one of these and explaining, hey, this is what this procedure is going to do, and what the patient should expect, so that we're educating the patient along the way. All right, residual. So residual should be approximately 50 milliliters or less. Basically, it means is when I urinate, this is how much I have left in my bladder. Of course, you're going to obtain that whatever I have left by either a straight cath or by ultrasound and figure out how much fluid is in there, okay? If there's tons of fluid left in there, then there's an issue because my body is not letting me excrete it all. And as you get older, they allow more residual urine to build up because things are not working quite as well as they used to. Especially your smooth muscles, as far as pushing down and excreting that urine. Alright, so that's your residual. Too easy. Dipstick albumin. Alright, remember I told you albumin is too big to fit through that filter on your nephron. And so if we have albumin in our urine, then we have got an issue. And this is on a scale of, I believe, 1 to 4. And we're looking for 0 to trace. Albumin. This is a urinalysis. You pretty much put a stick inside urine and you compare the color on the stick to your chart. And an indication that you have albumin in your urine is going to be an issue. Alright, again, it's your tissue paper and I'm throwing holes at it. As I continue to throw those holes at it via hypertension, via buildup of fluids, whatever the case may be, albumin is allowed to get through those bigger holes that are created by damage, renal damage. And when they get through, we have an issue. Okay, so we should have 0 to trace. Blood urea and nitrogen. Your bun levels, again, this goes back to your liver. Your stomach's going to break down your proteins. All right, from there it gets transferred to your liver. All right, your liver is going to further break down those proteins. It's going to turn it into creatine, ammonia, or urea. All right, so your blood urea nitrate measures the amount of urea in blood. Now, when they do this test, it look at the nitrogen on the molecule itself, but you don't necessarily need to know that. It's a blood urea nitrate. So when we measure this, we are figuring out how much urea is in the blood. Now, if there's a large amount of urea in the blood, we've got an issue. But there could be other factors. One, excessive protein, breakdown catabolism, breakdown of muscle. There's several factors here that can, in the opposite spectrum, not enough protein. Maybe they're vegan. Alright, so your blood urea nitrate measures the amount of urea in the blood, which should be filtered out. Again, it's small enough to go through your filter in your nephrons, so it should be filtered out by your GFR, or your GF. And your range for your blood urine nitrate is 60 to 20 milligrams per deciliter. But you're going to hear 15 as a standard kind of number. Now, understand that this can range greatly on diet, exercise, things of that nature. All right, creatine. When you hear the word creatine, all right, creatine, remember, is a breaking down of protein. The creatine itself, there's several ways to measure it. You can measure it by your bun creatine ratio, or you can also just measure it straight from the blood. All right, so in this regards, we're getting it from the blood. You also have that creatine clearance, which is far more accurate as far as your GFR rate. But your creatine in your blood is supposed to be 0.6 to 1.3 milligrams per deciliter. Now, I said creatine is small enough to fit through your nephrons, or your, I need to stop saying that, but your GF, your gallbladder filtration. It should fit through those tubules. So if we have a lot of creatine in our blood, then that indicates that something's not filtering right. If I have no creatine in my blood, then maybe I'm filtering too much. Either way, it can be an issue. So that's why proteins are so significant to assessing your renal system, is because we know exactly which ones should and should not be able to fit through your filtration tubules and through your bottom filtration. So an increase or decrease in those is what we're looking for, okay? And again, very important to understand what we need for the nurse's role, whether it be fasting, 3 samples, throughout the morning sample, take 3 samples and add it. That's an important factor. Now, that's going to cover your subjective and objective data minus your invasive procedures and the other diagnostics passed through UA. So we will look at that in the next video.